a drop in blood pressure, if you don't have enough oxygen delivery, it's something called shock. And basically it's a supply and demand, either oxygen or glucose, but is hypotension or low blood pressure same as shock? That's
No.
Right, so sustained hypotension will lead to shock. So in simplest terms, it just at a tissue level, you don't have adequate perfusion. That's the most simple definition of shock. So if this is a tissue, your artery, your vein, there has to be enough pressure for delivery of oxygen, nutrients, and when this is not adequately delivered, you have impaired tissue perfusion, which leads to shock. We know about ischemia, like heart causes MI, ischemic legs, and the brain is stroke, but other way to think of shock is just a global ischemia. The whole body is under hypoperfusion. So what we do in our hospital day-to-day, ICUs, OR, ER, I think our main goal is to maintain adequate perfusion. We do it day in, day out. We just don't think of it. If anyone is going under surgery, anesthesiologist monitors, blood pressure, flow, urine output, stuff like that. And his main ultimate goal is to maintain the perfusion. Now, perfusion is determined by two things, pressure and flow. The pressure part is the easier part. Why? Because we easily measure it. We have outline cuff pressures. You guys, low blood pressure, call the doc. What we're trying to do, keep the pressure up so that the system, the plumbing system, has enough pressure to deliver nutrients. A map of 65, we always target that. Why? So we'll talk more about that a little bit down, but there are studies done to see what adequate maps you need to maintain the perfusion. And there are different ways we try to fix a low blood pressure state. Pressors, fluid, inotropes, that's kind of the basics. The harder part of the perfusion part is the flow part, right? How do you measure flow at the bedside? How do you know if your patient has enough flow? And flow is nothing but the pump of the heart or your cardiac output. So your flow is determined by your heart rate and your stroke volume. And your stroke volume is each time your heart pumps, it's the amount of fluid it's going to inject. And at rest, the flow is about 3 to 5 liters every minute. When somebody is exercising, you need a flow of maybe 30-35 liters for Italy to maintain that level of perfusion. So at bedside, how do you measure flow? Clue, it's not ejection fraction. So how do you know what your flow is?
We don't do that. We don't measure cardiac output.
So how do you know your patient is adequately perfusing if you don't have?
By their appearance.
So that's part of it. What else? Urine output, excellent. What are the invasive ways of measuring flow? Swan, mainly. Used to be back in the days very popular. Some people say it's coming around. I'm not quite sure yet. But Swan, what it does is catheter sits in the heart. It actually measures your cardiac output. And when you divide the number by the body weight, it gives you cardiac index. So it actually gives you a live number on the monitor. Now Swan is fading out of favor. I guess before I trained, everybody had Swan. All patients with sepsis, ARDS, and then eventually the whole field changed, saying it's too much invasive procedures, complications are high, we don't really need it now. So why was that? I guess the poor man's cardiac output is generally what we go by every day.
Poor man's cardiac output.
Yeah, we go by urine output.
In the main ICU.
Your medication. Very good.
Thanks.
Your mixed venous oxygen saturation, that's something we don't do a whole lot now, but it still can be done. And what that is you actually measure your oxygen level in the vein, ideally close to the heart or your pulmonary artery. And when your SVO2 is low, that means your heart is not squeezing enough to give you more oxygen. So if it is extremely low, either you can give blood transfusion to get your more oxygen delivery, but more than 8, it doesn't help. Or you add some dobutamine or inotrope to increase the flow, increase the pump action. Now, early on I said it's not your EF. Why did I say that? Why is cardiac output and EF not the, why do they not correlate? So if someone has an acute drop in ejection fraction, let's say they're 65%, they're down to 30, those patients will have hypoperfusion. Your flow is essentially completely gone. But not every patient with congestive heart failure who gets admitted have hypoperfusion because their body has compensated over time. So they are kind of used to that low flow state. And those patients in times of stress, when they need more flow, you may have to add a little bit of inotropes, and sometimes we do that. So I'm going to go very much in details about lactic acid, but lactic acid clearance is something that kind of also gives us indirect measurement of flow. So once your lactate is 8, it's trending down, clearing up, then you know that patient is perfusing well. Because as we know, a lot of patients of ours are on dialysis, they may be on ventilators, mixed venous oxygenation. Again, unless you have a central line or getting somewhere close to the PA catheter, it's not as useful. So lactic acid clearance is a very good marker of perfusion and flow. There used to be, I don't know how many of you know what a precept catheter is. Yes. So precept catheter, when I was in training, was popular for sepsis patients because it gave you, it's a central line that gave you a continuous reading of your mixed venous oxygen saturation. It was popular one time. I'm not sure why it kind of fell out of favor, but there used to be a catheter called a precept catheter. And when the SpO2 was low, either we tanked up the oxygen delivery by blood or added inotropes. And newer technologies, kind of combined, it's called NICOM, non-invasive cardiac output monitor. So there are actually lots of devices out there now that can give you your cardiac output and your cardiac index by non-invasive or minimally invasive technology. Excuse me. They have some of them work on the arc line. So when you have the arc line, it looks area under the curve with every beat and calculates your stroke volume, and they have this algorithm which gives you the cardiac index. Some of them work off the chest leads, bioimpedance, and measure your stroke volume directly off the heart. I've used one more than 10 years ago. They're really good technologies. I think at TMC we have the minimally invasive arc-line one. I guess we hope to have it soon. So let's just put that one. But that will be something cool for some of these patients if you want to maintain that adequate flow. I mean, measure your cardiac output, make sure perfusion is good. So, kind of this is summarizing about what we know as shock. Essentially, it's about blood pressure and your cardiac output. And on your blood pressure is actually, this is the best, is like a plummet. Your diameter and your length kind of determines how much pressure is in the system. Obviously, your cardiac output is heart rate stroke volume, and diastolic and systolic volume. The difference gives you the stroke volume kind of thing. So let us discuss some basic types of shock. Hypovolemic shock. Where is the problem in this system? Usually the stroke volume. You're low in volume. The end diastolic volume is low because you're not getting enough fill. You might squeeze out everything you get, but overall your volume is low, hence your cardiac output is low, hence your blood pressure is low. So just because your cardiac index on a SMON or your non-invasive monitor tells, hey, your cardiac index is low, doesn't mean it's cardiogenic, because it still could be a volume issue. So sometimes that's why you give a little bit of volume and see if your stroke volume goes up. Hypovolemic shock can be hemorrhagic or non-hemorrhagic, GINS, that kind of stuff. Cardiogenic shock, usually problem is on this side as well. If it is somebody in complete heart block, they're not going to pump adequately. If it is somebody with acute MI, what happens to end diastolic volume in acute MI? It's
decreased.
Yeah, It goes. I mean, it can still be normal, but in systolic volume, amount of pump you're giving is not enough. So acute MI, CHF, heart block, all of those kind of sort of fit in this picture. Distributive shock. Give me examples of distributive shock. Anybody?
Sepsis from like electrolyte abnormalities or like septic versus not septic, so like a bacterial infection.
Right, so septic shock, one of the most common reasons for distributive shock. Usually the problems here are vessels are leaky. We tend to leak a lot of volumes. We need add pressors to kind of sort of tighten them up. But sometimes even in septic shock, there's a cardiac component. You have cardiac dysfunction, your EF drops down just because of sepsis. It's very reversible, but unless you identify it and help that heart out, it can lead to further complications. Another example of distributive shock, spinal shocks. Trauma patients can have extreme vasodilatation or anaphylaxis, diffuse body-wide vasodilatation. So those are some of the examples of distributive shock, essentially problems on this side. And your obstructive shock. Examples of obstructive shock. Called PE, big ones. You're not going to get much stroke volume. Your end diastolic volume is going to be, this is going to be high, this is going to be high, your net pumping is going to be low. So you're not going to have any forward flow in PE. What else?
Tamponade.
Say it again?
Cardiac tamponade.
Tamponade. Anytime your heart is not allowed to fill, there's fluid around it, tamponade and restrictive cardiomyopathy. Your just heart is have issue with relaxing the heart muscle. So based on kind of this, you can kind of classify almost all shock patterns and kind of identify where the issues are. Now, initially, the shock stage is on the very initial stages, there are compensatory mechanisms your body does. One is switches to anaerobic respiration, and we'll talk a little more about it down the line. But then your heart rate goes up so as to help the cardiac output. You have a little bit of vasoconstriction. Your urine output drops, trying to conserve that fluid and all that stuff. So early on, there may be a hyperdynamic phase. Your patient may have a normal blood pressure, a little bit tachycardic, may have a little bit of lactic acid. A lot of times people walking in ER may be in this phase. They come in, they look a little sick, you give them volume, they get better now. We tend to pick up the patients more in the last two aspects. It's very important they don't go to the hypodynamic phase of it and try and catch them early on. So in the progressive phase, things can still be reversible. Here they're obviously hypotensive, tachycardic, mentation is going down, urine output's going down, and there's obvious signs of shock. So these are easy ones to identify. These are all easy ones. I mean, they're usually in the ICU. The question between hyperdynamic and progressive, if you can catch them early on and reverse that process, the goal is to not progress. But this kind of usual stage. So what we do on a day-to-day basis, when you have a patient with low blood pressure, our first important step to get to the diagnosis, which kind of shock we're dealing with, right? So basics, nothing new here. Your history can tell you a lot. By history, a lot of times they may say either I'm not eating and drinking well or having diarrhea or stuff like that. If they are altered, they may not offer a good history. You may have to get a patient on a vent in shock. And in physical exam, most of our patients we can get from labs and imaging what kind of shock we're dealing with. But the importance of physical exam cannot be kind of, what's the right word?
Like lost. It can't
Yes,
be.
I guess. Cannot be lost.
Can't be forgotten.
There are a few cases I remember in my career where the physical exam made the difference. And this one guy, I remember in fellowship, he came from ER labeled as pneumonia on a vent. By the time in a few hours in 3 pressors, and we didn't know why. That X-ray didn't look that bad. But he was on a vent. He had a brace on, and he was African American with a dark skin, and I'll tell you the importance of that in a bit. But when I saw him, I just pushed on the belly, and he jumped out of bed, and was way out of proportion despite being on vent and sedation. So we took him down to CAT scan. It turns out there's nothing wrong in the abdomen. It was all necrotizing soft tissue infection he had under the brace. We had not taken the brace off because he had some back surgery or something, and apparently he had a breakdown of his skin. The bacteria had entered. So especially cases like septic shock, if it is a source control issue, no matter what you do, what antibiotics you do, what fluids you give, unless the source control is taken care of, the patient not going to do well. So if it's a surgical disease. Dealing with septic shock, one of our main goals is to identify is it something that needs to be fixed for the sepsis to get better. Other big examples, perforated viscus, right? No matter what you do medically, it's not going to work. Stone, when you have obstructed stone in the kidneys, till there's a nephrostomy tube in place or a stent in place, that shock is not going to get better. They are rapidly going to get worse. So some physical exam, a lot of times, just find routine run of the mill, but it's tricky on sedated patients if you don't do a kind of full body exam. Obviously, labs gives us clue whether it's MI or you're dealing with sepsis. Troponins can help sometimes. Lactic acid, again, that's our favorite lab in the ICU, so I'm going to go into a lot more details about it. And imaging, right? Imaging can help in situations. Echoes are very helpful in shock early on to distinguish you're dealing with cardiogenic component or not, besides CAT scan and stuff. So usually by these first steps, you have some kind of inclination on what kind of shock you're dealing with. And it's never in a totality, that just based on one thing you're convinced, because a lot of times you also deal with mixed shocks, and it's a lot more common than everything. So patients can have two different reasons for having shock, and you sort of make sure you're thorough in your history, physical, all the basic steps. Now, there's a concept of fluid responsiveness. Again, this is more on the side of septic shock, but when a patient comes in dry, right, if you start them on pressors, and if your system doesn't have enough fluids on, it's just going to squeeze those vessels without any benefit. So, are your patient fluid responsive? The non-invasive cardiac output monitors actually tells you, if you have one, it tells you if your stroke volume goes up when you give a fluid bolus. So again, back when I trained, there were no such devices. People with septic shock, and you all may have seen it, can get 6, 8, 10 liters of fluid. It actually causes worsening mortality. Your renal failure goes up, your pulmonary edema and respiratory flow goes up. Then the concept started changing where we have to give fluid but not too much. So the devices kind of tell you if someone is responsive more than 10% of the stroke volume. So if it gives you a stroke volume, let's say 45 ml every repeated beats, and it goes up to 65, that's a big jump. They know they are dry. And those devices allow you to reassess their fluid responsiveness. So you're not giving too much fluid. So then there's a concept of fluid restriction. Liberal fluid strategy versus restrictive fluid strategy. It did decrease the incidence of renal failure, respiratory failure in this patient. It didn't change the mortality when the studies were done. But that's what kind of was seen. So lesser the fluid ideally is better, but it's hard to make that decision at bedtime. Now, there are other ways to do at the bedside, trying to look for fluid responsiveness. So you give a fluid bolus and you see if the heart rate change or if your blood pressure change, and you know they are dry. Sometimes you give it and you don't see any difference. It kind of gives you a clue. It's not as scientific when you don't have anything in devices.
Do we expect to see that change immediately?
Usually.
So
if they're responsive, they should respond to it right
immediately.
away. And the bolus you give is usually over 5 minutes. So like 250 ml over 5 minutes, slam it in, see what happens. Kind of thing.
So that 500 ml bolus has a need.
And even respiratory variation. I mean, sometimes when they're on a vent, you can see that every time they breathe, your oxygen kind of, like not the number of oxygen, but you see a variation in your CVP. So if they have CVP monitor, you can see a respiratory variation. And when you see the variation with breathing, you know their volume status is on the drier side. So there are other kind of less than perfect ways to know it, but it can be done at the bedside. SIRS. We all have heard about SIRS in some shape and form. What it stands for is Systemic Inflammatory Response Syndrome. The important part is this is an exaggerated defense response by your body. Now, that means this patient can be tachycardic, may have febrile, then echypnic, and the white count can be high. These kind of the classic 4 things, and you need 2 out of 4 to be qualified as SIRS. Now, SIRS does not mean sepsis. So you can have trauma patient with the same thing. You can have pancreatitis patient with the same thing. It's just an inflammatory response in the body. Now, when you have SIRS with a source of infection or suspected source of infection, that's when it becomes a sepsis or severe sepsis. So just the concept of the SIRS, I want to put it out there. All right, let's go to MAP. Now, am I going too fast? Is that okay? Good. MAP of 65. So we talked about perfusion early on. Now, multiple studies over the year. This is one of the more recent one in 2018. They looked at, and this was a retrospective study, and they looked at kind of patients whose MAPs were that range, 55, 65, 75, 85, and they looked at the longer you are on a certain MAP, and what it shows is the longer time you are below 65, it actually heighten your risk for mortality, renal failure, myocardial injury, and so on and so forth. And even when you're too high of a MAP, I think some of the bad things also happen. So that's why traditionally this goal of 65 has come in over many years. Initial studies of all the pressors was done on MAP of 65. We kind of stuck with it, and this recent study just kind of confirms why that number kind of sort of 65 is important. So what about higher MAPs, 70, 75, or 80, 85? There were 2 recent studies, and one of them looked at MAP of 80 versus 85, and the other one not as high, like 75 to 80 kind of thing. Both of these studies did not show any mortality benefit compared to keeping it 65. So, yeah, it kind of, that number between 65 and 70 kind of still remains ideal. I think for a long while ahead, we don't expect it to change. All right, let's switch gears a little bit. Lactic acid. Probably, I think no other lab in the ICU draws out so much emotion, alarm, panic buttons everywhere about lactic acid. So let's get into a little bit of biochemistry and understand about lactic acid and what it is. So this is how in a cell in our body glucose is broken down. Glucose is your needed for energy. We all know that. Now what is it? Now when glucose comes, it goes through a process of glycolysis. It's just breakdown of glucose. This is what everything is about. ATP. ATP is your energy that all our muscles, heart, everything in the body needs. So glucose in a cytoplasm breaks down into pyruvic acid, gives you 2 molecules of ATP. Now, this is not as much, but what happens is this pyruvate goes inside the cell, furthermore in the mitochondria, goes through a process of Krebs cycle, if you all remember Krebs cycle from biochemistry, and gives you all these NADH and FADH. Ultimately, because of the oxygen, it becomes, you can generate 32 ATP. So 1 molecule of glucose gives you actually 36 ATPs, and that's kind of the bottom line of this. This happens in your aerobic circulation. So this is the same side on the right side. Inside the mitochondria 34, outside you get a net of 2, so it's 36. But what happens when you don't have oxygen, when you don't have perfusion, when there is not enough oxygen delivery, it gets converted, pyruvic acid instead of going in the cell, gets converted to lactic acid. Why does it do that? Your body still needs energy. So this process still generates 2 more ATPs, not 32, but at least some. This is seen in humans and all animals. In the plants, it goes into alcohol. So this is not applicable to us. Kind of reaffirming the same, this one is when you're in aerobic circulation on the left side, and essentially gives you all of that 36 ATPs. But on right side, it's pyruvic acid. When you don't have oxygen, you get more NADs. The NAD kind of goes back there, helps glucose get more pyruvic acid, so you can get more ATPs, and hopefully it gets to this part of the cycle when the perfusion is restored. Otherwise, this cycle goes in. So what ends up happening is you just generate a lot of lactic acid. Now, this is the Cori cycle. similar to Tori's cycle.
Okay.
So this Cori cycle, the significance of this in when you have a low perfusion state and low oxygen state. In your muscles, your glucose generates those 2 ATPs when there's not much oxygen. Lactic acid gets generated in the blood. The lactic acid travels to the liver, where it kind of gets converted back into glucose to go back to the muscle. So again, this is your body's defense mechanism to protect itself, and that's why lactic acid gets generated. Now, in a state of exercise, there's not enough oxygen delivery according to demand. This continues, there's a lot of lactic acid muscle buildup in the body, and as a result, your muscle eventually fatigues out. They eventually kind of exhaust all the ATP as well. So this is when you get fatigue and some kind of exercise tolerance with that. So why do we measure lactic acid? Let's see. You can answer now. What are we trying to measure with lactic acid?
Break down.
Say it again.
Break down.
Yeah, but why? Why do you need lactic
Why?
acid bedside?
Oxygenation.
Oxygenation or
Yeah.
perfusion, right? You want to make it's just a marker of perfusion. Anything you take them from this lecture, the lactic acid just tells you what your perfusion status is, and that's why we like to check it so much. So is lactic acidosis equal to sepsis? True or false? Wait, false. Take home message. Lactate doesn't mean sepsis. It just means perfusion. All shocks will lead to high lactic acidosis. Whether it's hemorrhagic, cardiogenic, all shocks lead to that. Now, let's look at the cause of lactic acidosis. Now, there's condition with increased production, and obviously we just talked about the tissue malperfusion, but other things can generate high amounts of lactic acid. You're exercising, seizures, cancer, and even COPD, asthma flare-ups. We tend to see that a lot as well, just because you're tachypnic and breathing fast, you're using all of your respiratory muscles, it just generates a lot of anaerobic respiration. Similar in cancer, which cancers can cause high lactic acidosis? So mostly it's blood cancers and lymphomas, which can have high cellular turnover. Those leukemias and lymphomas, you have extremely high turnover. But we sometimes always see with untreated stage 4 widespread cancer patients, they can have high lactic acid. Now, poor clearance is the other reason why lactic acid can get high, and we tend to see this more common than not when in shock patient with either cirrhosis or mostly liver failure and shock liver. So if you remember at bedside, you may have patients coming with shock, multiple pressors, who is clinically getting better, pressors are coming down and they're overall getting better, but the lactate remains high. Are they in shock liver? It's just taking its time to clear up. So that's why we don't really throw a panic button on that situation. This is the important part. What are types of lactic acidosis? Type A is the one that we talked about, the classic one. It's related to the shock itself. Everything we do, we kind of look for whether it's type A or not. I mean, that's kind of the key determinant in our head. Is it related to hypoperfusion or it's something else? Going back to the patient, if their blood pressure is fine, oxygenation is fine, they're maintaining fine, there's no signs of decompensated heart failure, flow issues, it's probably not your type A lactic acid. Sometimes we get a call from ER. Hey, patient looks fine, this is blah, 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 lactate's 8. Does it need to be in ICU as well? So you gotta try to determine if those patients who need to be in ICU is perfusion related or not, and hence there's something called as type B lactic acidosis. These are some of the reasons that are not related to low perfusion states. So metformin toxicity, it affects the Cori cycle, it affects some enzyme in there, and that can cause high levels of lactic acid. Now it is still very harmful, but it's not your true hypoperfusion lactic acidosis. We've seen quite a few cases over the years here as well. Patient come in sick and this and that, and they are on metformin, nothing else makes sense. And we kind of label them as metformin. Cancers, as we just discussed, asthma, COPD, as we just discussed, seizures, very common, lactic acid of 15, 20, 30, but within an hour if you recheck it, it's completely normal. that kind of sometimes helps us diagnose seizure in some patients. Okay, why is the lactic acid high and it's suddenly gone in an hour? So something happened acutely. And sometimes we also see decay and dehydration. That cusp of hypoperfusion / dehydration, they can have some degree of lactic acidosis. Important part at the bedside, remember these needs to be more like a rule out. Your first thought has to be, are we dealing with this or not? That's the key question. And if this you're convinced you're not dealing with this, then you start exploring this part. What is the other possibility of that? Let's talk about some zebras. Who has heard about D-lactic acidosis? So all the lactate we talked about is a L isomer of lactate, L-lactic acidosis. There's a concept called as type B lactic acidosis. It's a kind of, I've probably seen one patient so far, and maybe I think that's only because it was not me directly, one of my co-residents, but only because they are vigilant about it. But classically seen in people with short gut syndrome. So people with bowel resection, bypasses, when they have high intake of carb and carb overload, all their carb goes to the colon, the bacteria breaks it down into D-lactic acid. Now, our liver is efficient in clearing the L-lactic acid. It is not clearing the D-lactic acid. It mostly gets excreted in the urine. So you may have a patient clinically who comes with altered mental status, metabolic acidosis, something doesn't make sense, it's extremely acidotic and altered, and your history is they may have a short gut syndrome. Think about D-lactic acidosis. Our lab here, the one that we measure lactic acid, only measures L1. So there's some assays which will measure combined L and D, but I think it's a whole separate, different assay that would measure D-lactic acidosis. So unless you're thinking about it, again, it's a zebra, let's keep it in the back pocket. Propylene glycol. Some IV medications are kind of mixed with propylene glycol. I believe Ativan is one. So when you're infusing high doses of medicine mixed with propylene glycol, or if someone is taking propylene glycol toxicity, they can have a lot of D-lactic acidosis as well. And sometimes we see that in DKA. Forget the mechanism why we see that in DKA. So it's something that is extremely rare, but it's very different than your regular lactic acid. And I think for us it's a send out. I think we only need that one. All right, 11 take home points. Again, our main goal day in, day out, perfusion. Identify states of hypoperfusion, try and restore it. Identify what kind of shock you're dealing with. Be prepared with multiple ones. Monitor for your, if you know a patient in shock, on pressure, monitor them. Are they getting better? Pressures coming down, lactate clearing, urine output, mentation, the whole package. Lactic acid is a marker of, I said, perfusion or hypoperfusion. So when you have a patient with high lactic acid, first hypoperfusion or something else. Most likely we deal with hypoperfusion day in, day out. And then obviously you have to monitor, serially measure it, make sure you're clearing it out. But remember, lactic acid is not sepsis. Any kind of shock will go high just when you don't have enough perfusion. And always assume it's type A, the bad one, so that you're not missing that out, and then figure out everything else. So always assume the one is a bad one. Questions? Good? Everyone's master of lactic acidosis now?
Now we are.